great central ground. So what I'm going to do at the moment is to think a little bit about a manual therapy review of the sacroiliac dysfunction, which is largely related to ilial movement and ilial movement upwards and downwards. And the motions of the sacrum and the motions across this oblique axis, which are related to forward and backward torsion movements of the sacrum, will leave for a little while. So you're not just sitting there listening for a long time. All right? So, in your book, Book 2, there's a number of pictures of Olaf Evienth doing various things, and I'd like to sort of use that as the basis of our examination. So this is the muscle energy, not the muscle energy, the manual therapy examination at the moment. Of course, these are not mutually exclusive examinations. We fit them all together. But let's do this one to start with, see what the faults are, do a few corrections, and then we can go into the muscle energy so that it's a little bit more of a mixture of sitting, standing, working, sitting, and so on. Now for us, the starting point of all of this, isn't it, is the scanning examination. This is a sort of a key point. So because it's so important, I'm going to use a new sheet of paper and also a green pen. All right. So the scanning examination. It's only 3 days ago that we did what the conclusions were, all right, of this thing. And what we've got in terms of conclusions are that there is no neurology. Possibly there might be no myelopathy, that we might have, query, a spinal problem, but we've got an alternative problem, as Cyriax described this. And this happens to be a sacroiliac dysfunction. Now then, within our scan, we didn't stop and try and analyze this as we were going, what it's doing. We did the whole scan, the 7 or 10 minute thing, because these are so important. And it couldn't matter less if we've got a sacroiliac joint. If the patient has got this, we wouldn't be fiddling around with it. And if the patient has got that, a neurology, a neuropathy affecting, then this might be quite secondary to this. Although we may be going to address it, we need to sort of analyze that in detail. But within our scan, we've got that there's some restriction of spinal movement. Of course there would be if there's a sacroiliac joint problem, because it requires the sacroiliac joint to absorb this movement as it moves down into the lower limbs. So we've got that there's an alternative problem. Now, what tests can we reasonably put into the sacroiliac testing thing in the scan? We've got the compression and the flare, haven't we? Because Cyriax did that for medical conditions affecting the joint. We've got that. Now, is there another test that we could reasonably put into the scan? Because this is not very productive, generally speaking. If it is, it usually means there's a medical kind of problem, an inflammatory arthritis, one of the inflammatory arthritides of some sort. So it's not usually very good. So this is not a very great test, because we need a little indicating test within the scan. So I think it's reasonable in the scan that we perhaps use the kinetic test. That becomes part of the reasonable scan test of Cyriax. So if we've got the kinetic test now, we don't need to do it again, I suppose. Equally well, within the scan, we've got our positional things, because Cyriax, for various reasons, often to get the leg length thing and so on, but he did look at posterior suprailiac spines and things. And so we've had a look at the positions of these various things. So we can utilize, or we can transfer this information to our specific examination. If it's been done, sometimes we do it again because it kind of fits in nicely, and we're thinking about this exclusively now. So here's a sort of suggestion of a manual therapy examination, and I should have had this typed up, I think, now thinking about it, but you can write it down. Now that Kent is up to speed on his writing, there'll be no problem. Okay, let's see what this looks like. Somewhere this has to be done. It may in the scan, or we're going to do it all from scratch. The static positional analysis. Just have a think about this. And we compare the two PSISs. And we compare the PSIS with the ASIS, which gives us some idea of anterior or posterior rotation. In standing, we can do the kinetic test, and we can use a form of hiking. Is there any abnormal movement? What is the rhythm of how people do it, the sequence of the turning effect as they do this, and what is the balance on the standing leg side? Forward flexion test. This has been taken from the, not necessarily from the Muscle Energy, we did it before, because in 1952 Peterloo, who's a medical doctor I think, produced the forward bend test, coming forward like this and having a look at how the ilia move. The Muscle Energy has taken this a stage further and uses it as a non-differential test of ilial dysfunction. We'll talk about that when we come to that. Now then, are there any other tests that we can do? Yes, I think there are, and we can add them to this thing. One of them is the use of side bend like this. And let us say that side flexion to the left gives us an anterior rotation of the left ilium and a posterior rotation of the right ilium. So that's a useful test. A test that can come right at the very beginning, possibly, now we're thinking of the sacroiliac test, is one that you will see in Evian's thing, which is just in weight transfer or the efficiency of closed chaining on that side. So we just sort of transfer, can a patient do this, or are they reluctant? And when they get over there, can they just bear weight through that side? That seems to be, and you just sort of put your fingers in the sulcus at the back and on the posterior suprailiac spine and just sort of feel it give over, and it transfers the weight without the patient leaning over or doing some other peculiar compensatory action. We should be able to go from one leg to the other leg without a great deal of problems. If we've got a problem, we can't balance properly, or we don't want to bear weight through it exclusively, or whatever. So that's a nice little early test, and I would sort of suggest we might put that in there. We could follow that then with the kinetic test. We could follow that then with the forward flexion test. So that gives us various aspects. Yes, Anne?
With the side bending, looking at the rotation of the ilium, are you looking at the normal, or are you describing an abnormal?
No, I'm looking at normal.
That's backwards.
So that, well, this is looking from the back. So that as I do, look at me. As I do this, this should come into anterior rotation on this side.
The sacrum?
No, the ilium.
I thought you described earlier that it was the other way.
Shouldn't have done. As I go into side flexion on the left, I get rotation on the left into anterior rotation of the ilium.
That was different from what Diane described.
Okay? Then we'll test it out and see what happens.
Well, the slide that he showed that exact same thing, but I was wondering how that could occur.
Mm-hmm. Well, we'll just sort of see what happens.
It just seems like based on the orientation of the iliolumbar ligament.
Mm-hmm. If I'm in neutral and I go into side flexion to the side here, we should get an opposite movement of the L5 going forward, which would go forward with the ilium on that side. That's in neutral positioning, remember. So I'm in here and I do this. Side bend this way should go with rotation opposite. And so this should happen. Well, let's feel it and see what happens. See if you get any idea of that. If not, what I've been persuading myself for the last 2 or 3 years since I've been doing this has been wrong.
In the beginning you said there would be an anterior movement of the sacrum on the left side.
Well, I meant to say the ilium. I meant to say the ilium. If I said the sacrum, it's the ilium I meant to say.
You said ilium.
Pardon?
I have ilium in my notes.
Okay, whatever. Let's just say now that what I'm saying now is, and what that diagram from Diane's book says, so when I saw that diagram I thought, that's good, because that's what I think I've been feeling. So she's teaching the opposite now against a diagram.
I thought the diagram showed the reverse.
Well, it's a good thing now to sort this out. That's what's good about these courses. You can't get away with anything. Although it makes it a little bit more agitating. On early courses, everybody writes everything down and goes away and then thinks, I don't believe that, but they don't tell you. Let me see if I can find it. Okay, so this is a time out till I find the right thing here. No problem. We need to. Here it is. No, it isn't.
But we haven't moved everything in a different.
I don't know. We can find it all.
Where did it go? It was the picture straight out of
I think it's CF.
the way I've always remembered it is the leg length.
Do you use it as a test?
Not, it's to a certain event, but osteokinematically the leg you lean away from. Where did it go then?
Don't know. We've lost the transparency. That's kind of useful. Here we go. So what we're talking about is left side bending of the trunk, the osteokinematic motion of the pelvic content, posterior rotation of the right innominate bone and anterior rotation of the left. Okay?
Yeah, I read it wrong.
Okay. Okay. Here we are. Here's the diagram. It's a good thing to sort of sort these things out best we can. Okay, so as we go into left side flexion of the trunk here, I'm only doing this as left side flexion. It's no point in testing rotation because it's too hard to cut rotation down into the back. At least when I do this, not a whole lot of other stuff is taking place that confuses me because everything comes back. Okay, so as I do into left side flexion, what I'm saying is that in left side flexion, this one on the left hand side here is going, on the left hand side here is going into right rotation, coming forward. Anterior rotation on the left-hand side, okay? So as I do this, okay, like this goes forward, that one comes backwards. We can feel this and see if you feel the same thing. I mean, that'd be the best way of doing it. If we're all having difficulty in feeling it, we abandon it as a test.
We just kind of played around with, a lot of that depends on what position in the sagittal plane L5 is in.
Sure.
It's not exactly neutral, if it's split forward bend, then the opposite would occur.
Sure, and so it's perhaps not the greatest test, but if we've sort of got a reasonable function in the lumbar spine, then I think it's a useful, quick thing. And none of these tests are, totally gone. Yes?
Can I say something?
Sure.
Sure, go ahead. If we have a left lateral flexion, it will end up to be a right rotation of the spine. in neutral. So the sacrum will have a right rotation. Isn't it that the sacrum first goes anterior and then the ilium will follow? So that it is a relatively posterior movement of the ilium on the sacrum?
They're calling it osteokinematic.
You're talking arthrokinematic, and I think that sort of confuses us. We are always going to be feeling, or we're going to be feeling in this regard, osteokinematic movements, aren't we? We're feeling major movements, not feeling little glides or anything like that. We're feeling basically what happens. Now, how it happens, I don't really know. I mean, I would sort of, I don't know if I'm generating the movement from above downwards, I would think that the forces would go down from 4 into 5 and into the sacrum. That's where the force is coming from. If we were doing something from below and the ilia is moving, then we're pushing the movement and the stresses from here into the spine and going up. So that might be sort of relatively opposite. Yes?
Not to confuse things, but can I also clarify that do we allow the pelvis to translate sideways? So
No.
So the focus, you keep
No,
the pelvis
no.
still
Yeah,
sideways.
yeah. So it's this, the normal way of doing it, of course, is we always do this. But when we are sort of examining people, we try to keep them more or less in a plane of just coming over like this. Otherwise, it gets so confusing in terms of what we do. And the only time I ever do that is when I'm having a look at the correction of a lateral drift. Yes, Dave?
So what you should feel with this, the PSIS actually comes up on the side that you're side bending.
Side bending too, yeah. And I found, you can persuade yourself, this is what is so important about this, and I really like to tell you this, you can really find what you want to find. This is really so important. You look at something, a good test, and you start to find this, and somebody comes along and tells you, no, I find exactly the opposite, and you think, well, what's going on here? And so we've always got to be sort of saying, it's really worrying to me, this palpatory stuff that we come up with, all these theories, and in fact we might be sometimes wrong. Hopefully the more agreement we can get, the less we're going to be wrong. But it's good that we challenge, whoever's saying any of this stuff. But what I found with this is that it's not bad if I've got somebody who's in, let's say, a posterior rotated position, and I'm a little concerned about whether it's just the shape of the ilia, because that's a big problem too, isn't it? Are we just looking at a different shape on one side as compared to the other? And so to sort of have a look at the side bend motion coming over here, and if it's posteriorly rotated, it seems to me that side flexion will be a bit restricted because it cannot bring about the correct compensatory movement in the ilia. So that's kind of how I use that. I prefer this test as a sort of key kind of test. It seems to be less and it seems to be less subject to all kinds of variations, and it has actually been produced in a number of quite prestigious journals. It's in Cicaldi-Willis's book, and so this test is probably the less controversial one. This test in Canada, we had a lot of problems agreeing on what was happening, almost to the extent we thought we should abandon it as a test. So here we are, we've kind of got all this stuff, and I think we've just got to work on it and be quite, critical of what we're doing very much of the time.
Shouldn't there be, with all these tests, there should be they got to be complement to each other or correlating to each other before you,
Yeah.
One test.
Yeah.
What does the one test mean?
One test means very little. It's got to fit in, and we've got the scan which tells us what general stuff is going on and what very specific stuff is going on, and then we can go into this and look at that. So this is reasonable. Yeah, okay? Right. Can we go on now, Anne? Okay. Sitting, okay? And there's going to be some sort of influence with muscle energy here, I must say, as we go through. But sitting, essentially what we can use sitting for is to have a look at leg length, can't we? And so we can compare these in sitting and in standing. There's no doubt that in sitting there are slightly different things go on in the sacroiliac joint. Monell used to have a test where he compared the distance between the posterior suprailiac span in standing and in sitting. And it should get greater in one or the other. Now I can't remember what happened here, but there was all sorts of problems, because if you sit and you slump, it's a whole lot different than if you sit and you do this. And that was never clarified all that well. So I use this essentially to look at leg length. But the forward flexion test in sitting seems to, according to the muscle energy people, stress sacral problems. So they use that as a non-differential suggestion that you should be looking for some of the sacral abnormalities later times in the testing. So it's just like a little thought processes that sort of sets you up. Now then, compression and iliac flare. Well, we'll just have a complete list of stuff. This straight leg raising, 1 compared with 2, I should take that out. I don't think it's good enough to be part of our testing. What was it? It was that if you lifted one leg up and it caused pain, and then you took the other leg up and it kind of relieved the pain, it was because it symmetrically stressed the sacroiliac joints and took the asymmetric stress out. Whereas lifting both legs up should be more stressful on the lumbar spine than it is on the sacroiliac joint. So if the pain increased with 2 legs as opposed to 1, you thought of lumbosacral spine, and if it reduced with 2 legs as opposed to 1, you thought that it was a sacroiliac joint. But I've not found that great. I had a doctor that came in. You know how you like to make brilliant improvements with doctors, hoping that they may send you a few patients. It always surprises me that they and the family will come and they never send you anybody else. I never understand this. But this is what this guy, he was a good guy, this one, and then he did send me a lot of patients. So he came in and looked at this, and this is when I was doing these tests, and I found that 2 legs was considerably better than 1 leg. So I found the sacroiliac dysfunction. I mean, it was there, but obviously it wasn't the big thing, because about, 2 months later, he had a large prolapse removed. So this is what had been going on. It wasn't evident to me at the time, but that's what was going on in the spine. Obviously there was dysfunction, not to have reached a level that I could measure at that time, but that this test, I would have thought, because it was the lumbosacral, would have produced some reaction. It didn't. When I lifted both legs up, it was better than when I lifted 1 leg up. So I figured, okay, here we've got sacroiliac dysfunction, not lumbosacral dysfunction. So from that time on, I abandoned it on 1 patient. Ligamentous stress procedures. Okay, we're going to look at, procedures spelt wrongly, I see there, is it? Yes. Looked at in terms of sacrotuberous, sacrospinous, posterior sacroiliac. So this is a convenient place to do that. We can palpate Baer's point here. B-A-E-R''S. We go to the anterior superior iliac spine, and you go about 2.5 centimeters in and press. And I don't know what you're pressing on. I think you're pressing on the anterior iliac fossa and iliacus. Some people kind of describe this as being on the anterior part of the sacroiliac joint. There's no way you're down there. But you're coming across here, and it's very tender. And from Lewitt's earlier studies, he found in children with sacroiliac dysfunctions that all of them were accompanied by marked iliacus spasm. And he could either manipulate the joint and relieve the spasm, or he could inject the muscle and alter the dysfunction. So there's obviously a big relationship between iliacus and the sacroiliac joint. And that's what I think Baer's point is. There's a wonderful set of very old pictures in Greg Greaves' book, second book, the Green Book, on common vertebral joint problems of Baer. Okay, 1923. With articles placed in the Journal of Bone and Joint Surgery with some of his conclusions and treatment. Okay, here we've got somebody that's immortalized himself with Baer's point. And what do you see? You see these patients who are standing like this, who now, after Mixter and Barr in 1935, we would almost certainly say a discal problem, not sacroiliac problems. Straight leg raising, you see him lifting this leg up, 30 degrees, somebody like this, 30 degrees. What was the treatment in those days? To take them down to the theatre, to lay them on the bed and anesthetize them, and to force this stiff straight leg raising. And so now we've got these patients looking like at the photograph like this, laying on their backs with their legs up here, right up the chest wall, right up here. So here's this limited straight leg raise. Now he's got it right by the shoulder. Can you imagine the damage that was done to those nerves? And this was the big thing. You know, you kind of wonder, well, people will be looking, we're talking at break at what we're doing now and thinking, wow, those people were right out to lunch. But you look at this and that's not so long ago. That's literally amazing, but bears point. Now, joint motion. There are several positions that we can look at joint motion. This is passive joint motion of the sacroiliac joint. We can have the patient in prone lie, in supine lying. We can bend the hip up and we can just fit our fingers in the sulcus at the back and we can just move the sacroiliac joint about a little bit and see whether there seems to be a little movement going on. We're not looking for anything particular. We're looking for just the give in the joint. So this is one place we can do it. We can actually lie the patient in side lying after this. We could roll them from having looked at the pubis onto the side, and we can just do a little in-flare, out-flare movement of the pelvis and feel the sacroiliac joint and just see if we can feel a little give. That's all we're trying to do with this joint. See if it gives a little when we put a little stress on the joint. We're not looking for definitive glides in all sorts of different directions, because that's going to depend upon these irregular joint surfaces. Next thing we can do conveniently in this is palpation of the pubis. And we'll do a little exercise here in terms of making you more comfortable with this area. And certainly I think we need to be able to palpate in a reasonable way along the inferior ischial and the pubic ramus, so that we can look at the muscles from adductor longus, adductor brevis, the gracilis, and the adductor magnus, all the way back to the hamstrings. Now obviously this needs us to be able to do this in a professional way and be able to test as we're going back, and so we should be able to do that reasonably easily. All right, so those are the tests we can do in the back lying position.
Could you just again give your description of Bear's point?
Yes, we're just coming anterior superiliac spine. I'm coming in about 2.5 centimeters. It's often thought about along a line drawn from the umbilicus like this. I just usually come in and just press back because I think it's the umbilicus, so I just sort of hook my fingers in and press back onto the anterior iliac fossa. That's what I do with this. And it may be that it's good to do this in prone line, where you can fit your finger underneath and push up and outwards. So if you've done it in one position, you wouldn't need to do it in the other. Okay, now we'll just take a moment here because...
That's bilateral.
Yes.
Because they always show that the text always, you always think of it as a single point, like
Yeah,
Bernie's point.
you compare it both sides. And it's very close to McBurney's point, so a lot of these were talked of on the right side as grumbling appendices, you know. Okay, here we're on to the prone position now. And we'll kind of mix this up a little bit when we get to the tables with the muscle energy, so that we don't have to do everything sort of like differently. Prone lying, we can inspect the gluteus.